Good morning, everybody. So I'll be talking on the 15-year outcomes after monitoring surgery or radiotherapy for prostate cancer. This is also commonly known as the PROTECT trial, which you all are quite aware of. This is published in the New England Journal of Medicine 2023. The previous 10-year outcome was presented in 2016 in the same journal. So what is extra is what I'll be talking about. So what they did is in the United Kingdom, they took localized prostate cancer from 1999 to 2015 over 9 centers. A total of 1,643 patients belonging to 50 to 60 years of age were randomized into 3 groups. So there was one active monitoring group, there was a radical prostatectomy group, as well as a radiotherapy group. The mean age of diagnosis was 62 years. The PSA was 4.6. And at the initial stage, 77 was deemed to have low risk, that is Gleason grade of 1. So they were, as I said, randomized into 3 groups. One is the active monitoring, one is the prostatectomy and radiotherapy. They were all comparable. The primary outcome was prostate-specific mortality rate, whereas secondary was death from any cause, metastasis, which defined as metastasis on imaging or a PSA more than 100, clinical progression including meds, a higher T staging, initiation of long-term ADT or any local complications, or long-term ADT alone. So what is the 10-year study? I'll just mention a little bit about the 10-year study also. So 10-year outcomes from till 2009, they showed that the prostate cancer death was overall low. And they showed that a radical treatment, radical prostate or radical radiotherapy had a lower incidence of progression or meds. But however, it did not translate into a higher mortality. After 15 years, they had a very good accrual rate. Their data was fully captured for 98% of the patients. But they did see that compared to the previous risk stratification groups, the newer risk stratification groups showed an increase in the risk. So there are more people at intermediate risk, more people at higher risk. And they saw that post-radical prostate, at least 30% had an increase in pathological stage to T3 or T4, and 32% had an increase in the lower grades. So the grades were not very low as compared as what they thought initially. The primary outcome, they saw that death from prostate cancer, the survival rate was very good among all the groups. It was 97%. They did not find any significant difference between all the 3 groups with regard to prostate-specific survival. Coming to the secondary outcomes, again, there was no difference in the death from any cause among the 3 groups, but in all the other 3 groups, whereas metastasis, long-term ADT, or clinical progression, there was an improvement in the survival in radical prostate and radiotherapy compared to active monitoring. So this is again showing the survival analysis, whereas in the prostate-specific survival, there was no difference in the graphs. Whereas if you see metastasis-free survival, active monitoring did do a bit less compared to radical prostate or radiotherapy. What was the change in management? In active monitoring, they saw that at 10 years, around 54% had a change in the management to radical prostate or radiotherapy or other treatments. Whereas at 15 years, there was 6.3% increase to 61%. 61% of people of active monitoring actually underwent some other treatment, such as radiotherapy or some other surgery. In the end, what they saw was 24% of active monitoring people were alive and received no treatment. And out of these people, around 12% were intermediate risk, and 14 and 10% had a Gleason grade score more than equal to 2. So these are people who are alive who received no treatment, and they did find some intermediate and high risk in these patients also. They did a subgroup analysis seeing various factors. In that, only one thing was significant, whereas in patients who are less than 65 years, they showed that active monitoring or surgery had a lower risk of death than RT. Whereas more than 65 years, it was RP and RT, which was better than active monitoring. When they saw the Gleason group, when the PSA clinical stage, there was no difference in the subgroup analysis. So what is the discussion? The prostate cancer has a very good survival, 98%, even at 15 years median of follow-up. The radical treatment did show, like surgery or radiotherapy, decreased incidence of meds, local progression, and decreased the ADT by half. But however, this did not translate into a better prostate cancer-specific mortality. So what we need to do is more aggressive therapy sometimes can do more harm. We have to consider critical trade-offs between the treatment long-term side effects as well as progression. And there are limitations to the risk stratification progress that we have now. Earlier, they found that a lot of patients were at low risk, but when they actually stratified better, there were more patients intermediate and high risk. Even in patients with metastasis, there was good survival. And now it arises the question, but can we actually take metastasis as a surrogate marker lethality? Because it did not translate into a worse mortality. Most of the metastases that were seen in active monitoring were to lymph nodes, whereas visceral and distant metastasis were similar in all the groups. And rates of local progression, there could be bias because this was done very early. MRI was not used. All the stratification was because of for DRE and CT scans. Active monitoring, like I said, 61% underwent RP or RT 15 years. This is similar to the other trials, SGPT and PCPT trials. And there was no evidence of treatment difference among the groups, the subgroup analysis, except age. This study had good strength, whereas they had a very good high level of randomization. They had standardized treatment pathways and very good follow-up rates. Limitations, I would say, because of the earlier studies, there is a constant evolution of diagnostics. Newer treatments have come, and they were not using MRI or PET scan to initially stage or even follow up the patients. And the active monitoring protocols were less intensive. They did only a PSA follow-up. They did not do MRI. They did not do repeat biopsies. So to conclude this PROTECT trial, it shows that overall prostate-specific mortality is very low. They have a very good survival. And there is no increased prostate-specific mortality among all the three groups. But active monitoring did have a higher chance of metastasis, higher progression rates, but this did not turn into a higher mortality. So the choice treatment, we have to weigh trade-offs between benefits and harms and decide carefully. Thank you.
Good morning.